Thank you very much. First of all, I would like to thank Dr. Kamal Sharma for having me over here. And it's an honor to be speaking in front of our teacher, Dr. Gambhir, and everybody. So, I require the permission of the scorers and everybody else to begin the bout. So, my topic is rotablator is the gold standard. Dr. Kamal has given me this case, and now I'm going to talk about why rotablator remains the standard of care. So, it's a 30-year-old technology which has stood its time. More and more devices are coming into the market. However, rotablator still holds its ground. Today we have IVL, then we have laser, we have orbital atherectomy, which some cases have been done yesterday. But rota, I think, is still a gold standard, and I will prove and I'll convince you why it's a gold standard, because we have data. We have large data, we have 30 years of experience, and we are still going on and on. So we look at this. Rotablator was invented by Dr. W. Oth in 1980, but it came into practice only in 1996. We have one of our pioneers in the country, Dr. Gambhir, sitting here, might have done the highest number of rotablators in the country as of now, right from... Yeah. So, I've been listening to his lecture from our DM days, from first year onwards, so it's still the gold standard, and he can vouch for it. So there is a strong clinical data supporting rotational atherectomy use. So let me take you to some data and registry why I say it's a gold standard. Then I'll come back to the case which Dr. Sharma has put up. So if you look at the old trial, Rotaxis trial, which was there with rotablator with the Taxus stent, this is first generation Taxus stent, and with the other arm was PTCA plus Taxus stent with the rotablators, and the second endpoints, as you can see, is MACE at 9 months. So if you look at this study, rotablator with rotablator and without rotablator, the success rate and slow flow, no flow dissection perforation was all equivalent in both the arms. And if you look at the late lumen loss was comparable, and the other things like death, MI, TVR, everything was number wise, it was slightly better in the rotablator arm. P value may not be significant, but this trial showed that rotational atherectomy is here to stay for a long time. Then came Prepare Cal's study, which had comparison between a modified balloon, that is scoring balloon, cutting balloon versus rotational atherectomy, and they had a 9-month and 1-year follow-up, and then the strategy success was superiority. So if you look into both the arms, the procedural duration, fluoroscopy time, contrast volume was more or less the same. What was good was large dissection was much lesser in the rotational atherectomy arm, and even the side branch compromise was much lesser. So we all have seen that in our day-to-day practice. Second thing was the strategy success was higher in rotational atherectomy arm, because there was a lot of stent failure in a balloon angioplasty. They were not able to put in stents, whereas in the arm of rotational atherectomy, the stent failure was very, very less. So preparing the lesion and understanding the lesion, reading the angio properly, and taking the rotablator up front will definitely take you in a long way. So if you look at the 9 months primary endpoint in stent late luminal loss at 9 months was more or less both were same. So primary endpoint for non-inferiority was met with no statistical significant difference for clinical outcomes at 9 months. Then came Euro 4C registry, which had a large number of patients, and this was analyzed for 30-day and 1 year up. And the second endpoint, the primary endpoints were composite safety endpoint, and in the occurrence of the MACE, which has been mentioned over here. Here, real world cases were taken. For example, patients with diabetes, peripheral vascular disease, chronic renal failure, and CTOs, left ventricular dysfunction, unprotected left main, all the groups were included in this. So, if we look at the in-hospital complications, more or less was safe. So, it was stated that rotational atherectomy had very low complication rates despite including a highly complex patient group. So, it also demonstrated that low complication rates were there in highly complex patient, and this was the all-cause death and MACE, which was all comparable. So Europe 4C takeaway points were real world data demonstrate that rotational atherectomy is safe and effective with low procedural complication. After 1 year follow-up, MACE were acceptable. Using IOS and DES can further improve the outcomes. Then came rotate registry, which has included a large number of patients, 1000 patients, and then the primary endpoint was, these are all registries, and primary endpoint was MACE at the end of 1 year. So if you look at the MACE, the in-hospital MACE, 1 year follow-up, 2 year follow-up, stent thrombosis were all acceptable. So rotational atherectomy results in high procedural success rate with acceptable short and long-term MACE. This was what was concluded from this particular study. What is interesting was we have seen many European operators telling that once you think rotational atherectomy is needed, just go for it and don't make it as provisional. There's something called rota regret. You know, we've gone through it once in a year. We go through rota regret, and we always sit back and think and realize that we should have used the rotablator upfront. So what happens if you use a rotablator upfront? The pre-dilatation balloons are less, your procedure time is less, fluoroscopy time is less, and contrast volume is less. So the overall outcomes are better in terms of all these modalities when you use rotational atherectomy upfront. SCAR was a very interesting study which was published in 2020. So this was one long-term data started in 2005, and then they studied the patient up to 2016. So divided into three group of patients depending on the time duration, and then they looked at the MACE, 4-year MACE, and the secondary endpoints like major non-CBG in-hospital bleeding and major and minor in-hospital bleeding. So what they saw, there was an increase in the procedures with rotational atherectomy. So in 2005 it was only 0.5, and 2016 1.2. So there was a jump every year in the use of this device. Then adjunctive device were used, especially more of transradial, drug-eluting stents, and of course imaging, which was adapted. Then complexity, more and more tough cases were addressed with rotablators, advanced aged and comorbidities and high risk profile. And improved outcome rates were also there. So these were from 2005 to 2016, the complexity and everything went on increasing. So if you look at 3-year cumulative restenosis rate, right from 2005 it was 11.1%, which came down to 4.1% in 2015. Obviously we know the reasons, because the improvement in the stents, the imaging, adjunctive devices, and so on and so forth. Even the MACE from 34.2 in 2005 came down to 29.2 in 2015-16. Other complications were also quite comparable, and despite increase in patient complexity, major in-hospital complication remains low. Then there was a major debate about low speed and high speed rotablator. So low speed, now I think of course sir will tell us that I used to do rotablator for all the patients at 180,000 revolutions, but now I realize 160 is better, because the slow flow and distal embolization is much better with the slow the speed less than 160. So this was one arm where they used speed of 135,000 per minute, and with conventional balloon angioplasty, and they followed this patient. So the low speed showed good outcomes in terms of reducing probably slow flow and no reflow and distal embolization. And among this, there seems to be a trend to increase in the survival in patients with when used with low speed ablation. Then there was an issue about operators who are doing large number of rotablators versus operators who are doing less number of rotablators. So what happens to this kind of outcomes? So this was in the UK National PCI Registry, where they divided into 4 quartile: high volume, moderate volume, low volume, and very low volume operators maybe doing this thing. But what they saw, even in this kind of subset, the complications rates were low, despite this significant less in hospital MACE and major bleeding as as the operator volume increased. So what are the advantages of rotablator apart from the robust clinical data and 30 years of experience? Easy device trackability post rotablator, we have all seen that. Time tested therapy for intracoronary calcium is cost effective, US FDA approved. Of course, my colleagues also will argue that IVL is also US FDA approved, but we'll talk it at the rebuttal. Forward burrowing motion, optimal bed preparation calcified segment, differential cutting, long diffuse calcified lesion, as this case we'll discuss. Limitations are deep calcium, steep learning curve. I don't know whom to blame this, but I agree with this, because a lot of people have not been exposed to this in spite of being 10 years of practice. There's limited number of people kept it in their pocket and they were doing all these things. So this point is blamed for ours. Pre-existing dissection in lesion segment. Well, not all dissections are contraindications to rotablator. Maybe non-flow limiting dissection, we have done it and we've been doing that. Wire uncrossable lesion, yes. SVG grafts, yeah, we have no experience and we don't do this. In-stent, we are doing that now. After the imaging has come, we have been doing in-stent. Maximum burst size available is 2.5. That too very rare. Even 2 millimeter bursts are not available sometime. So I don't have the same case, but I had this similar case which Dr. Kamal Sharma mentioned. 70-year-old patient, NSTEMI, and if you look at this long calcified stenosis, and he said NSTEMI, and as you see the TIMI flow in the LED is not very great. So it fits in all the criteria of Dr. Kamal Sharma's case. Now, from which angle does an IVL will actually go into this? So, if you are given an IVL and rotablator, obviously the first choice is rotablator. There is no question about it. So one of my colleagues started pre-dilating it, and I was not there at this time, and he started pre-dilating. If you see all the things, and then after pre-dilatation, nothing could go in. Even there was a great difficulty for the microcatheter to go in. Probably there were nodules all over the place. So this was the situation. So what do? So I jammed the microcatheter halfway through, and then fortunately the rota could go in, the rota wire could go in, and this is a 1.5. I'm not showing all the details, but this patient had adequate dissection in spite of that, but we had no choice. The nothing was going in, NC balloons were not going in. So this is a 1.5 burr, went all the way beyond the mid segment, slow pecking and taking own time and make sure you don't get into complications. So as you can see, post rota, obviously there's a lot of things happening down there. The flow is reduced, but all those things can be taken care. So serial dilatation with 2, then 2.5, then probably we used 3, so you can see all those things. Then we used OP and NC balloon in the mid segment over here. I was not sure, but cutting balloon, but however OP and NC balloon went in, and after that plaque modification, TIMI III flow came, patient was stable, and now we are all ready to go ahead and put stents. So this is a distal stent, long one, and this is a proximal stent, and then optimization, and this is how the result looks. Good TIMI III flow and no compromise of the side branch, and no edge dissections. I'll come back to the slides in the rebuttal, but however, rotablation is a useful, indispensable device in interventional treatment of heavily calcified lesions and essential tool for complex PCI. Optimal technique and strategy are pivotal to avoid any potential complications. rotablation remains an important rescue device in uncrossable and undilatable intracoronary lesions. Rotational atherectomy is prone technology with huge global database. Rotablator is cost effective. Do I say anything more? I think the knockout is already there. Thank you.
So good afternoon, everybody. Thank you, Cardiocon, for having me as a speaker here in this August conference. Respected sirs, Dr. Gambhir sir, and seniors like Dr. Anand Rao, who just preceded me, and my dear colleagues and juniors who are gathered here. By the time they get my slides ready, I would just like to mention the blue part has already accepted, I believe, a knockout. The only change constant in this world is change. So 3 decades of a device or a therapy does not mean that there is no place for a new therapy. And we clearly know that new therapies are here to stay. And we know that for not only for calcium, but for all other modalities of treatment that we interventionalists are gathered here for. So my job is much easier because my preceding speaker already confessed to certain problems with the therapy that he was so confessing about, and which he very conveniently, hid certain parts of the talk, under the garb of, you can say, effectiveness and, ease of use. When I'll show you my slides, and also I will show you the same slides which he showed to a certain degree, because data is like a mini skirt, right? It hides more than it shows, isn't it? So, or the other way around. So, we can look at the data in both ways, and, we can still have a different picture. And by the time that we start, we as patients or as young interventional cardiologists who have just passed out, by show of hands, we can say that if given a choice, say possibly if you leave out a cost to a certain degree, and with the ease of use and the learning curve, if given a choice to use Rota or an IVL, what would you actually use if given a choice? Please raise your hands as a patient or even as an interventional cardiologist. Raise of hands. Nobody will use IVL. All will use Rota. Don't be afraid. Sir is our friend only. He will not physically harm you.
You can ask this question later on.
No, I can start with straight away.
Or,
yes, sir.
Let it be left to
Sure. All right. Yes. Okay, so looking at this case, we didn't have the images, but we assume that the clinical details were something like these. A 70-year-old gentleman who presents with non-STMI, ST depression and deep T wave inversion in anterior leads on ECG. EF is 45%. Positive myocardial perfusion nuclear scan for ischemia at low workload in LED territory. And the angiogram presumably, so we are assuming certain things, is a 99% calcified long tortuous LED lesion with already having a slow flow, a TIMI II flow. So there are certain things which you can clearly focus on. You know that there is a clinical presentation, patient has a chest pain, is a significant angina, already nuclear scan is positive, so there is definitely a problem there, needs to be tackled. And if you look at the angiogram, clearly mentions that it is a critical lesion, there is a long tortuous LED with pre-existing TIMI II flow. Unfortunately, we do not have any imaging data, which as a preset with Dr. Gambhir also mentioned, with left main plasties, not all are same, but yes, imaging is here to stay and is an important part and parcel of all chip cases. So any calcified lesion which you treat today without imaging, you only are looking at part of it. You really do not know what is going on there. You do not know what amount of calcium it is, what type of calcium it is, what is the thickness of the calcium, and actually which segments are the ones which are most calcific and require the most amount of therapy. And again, financial situation we do not know. So these are issues with this particular case, which would guide us in selecting the type of therapy that we would look into it. So now, what are the implications of coronary calcification? Before we go on to the modalities of therapy and looking at this particular case and comparing the therapies, what are the implications of coronary calcification? Why is it important and what do we need to do about it? So if you look at coronary calcification, what it actually results, we all know here that it results in impaired stent delivery, there is a decreased stent expansion, there is increased malapposition and stent asymmetry. So ultimately you do not only have acute procedural complications, but there is also long-term problems in the form of stent thrombosis and restenosis. So when we look at this slide, you just concentrate here, you can see that with the arc of calcium going up, you can see that the stent expansion at a standard expansion rate of say about 16 atmospheres, you could see that the stent expansion percentage goes down, right? And same way as the arc of calcium increases, the stent expansion percentage goes down, and the use of therapies like say rotablation, for example, the use of therapies go up. So it is very, very clear that you need to do something for a certain arc of calcium, but you can't assume this on angiography alone, because angiography is just an estimation of the amount of calcium. But whether it is adventitial, whether it is intimal, whether it is medial, whether it is a circumferential, whether it is a localized, whether it is a nodular, eccentric calcium, we simply cannot judge only from angiography alone. And that is why, when you compare coronary calcification vis-a-vis no calcification, you could see that the acute result or the target vessel failure is much higher in the presence of it rather than in the absence of it. And similarly, when you look at the particular trial, a large trial like an ADEPT DES trial, you look at the event rates, and if you look at 2-year events, they were so high when you actually put in an under-expanded or a mal-apposed stent. So it is very, very clear that you need to do something for these particular patients because they are simply very, very high-risk patients. So what do you require for a preparation of a lesion? So you require a luminal expansion, and you also require a plaque modification, right? Because it will facilitate your procedural success, and further it will also minimize the vessel trauma, and thereby you will achieve what is the goal is to achieve a higher MLD, right? Post calcium modification. So that is what is achieved by these therapies. So now when we look at these therapies, what are the treatment modalities which are available to us? So in the present scenario, you could see that, when you look at imaging and when you look at these stents, it is such a hard, calcium is such a hard substance. It's almost like a bone. When you put in and when you pull out material like this, you can actually have something like this. So it is simply very, very abrasive, and something needs to be done for it. So what are the modalities? You could clearly see we have got NC balloons, good quality NC balloons now coming in. We have got cutting and scoring balloons, right? Like say angiosculpts and Scoreflex and whatnot, right? We have got laser, as sir mentioned. We have rotational atherectomy, which has been there with us for the past 3 decades, and we have orbital atherectomy. Now we have got laser atherectomy, which has already started. We have already done orbital and laser cases, right, in the near past, and now we also have IVL, not to say the least, right, which is intravascular lithotripsy. So when you look at the guidelines also, what do the calcified PCI guidelines mention? When you look at a cutting balloon angioplasty, right, there are limitations to it, right? Certain osteal lesions, fibrotic lesion, moderately calcific lesions, it may simply work, or as an adjunct to a rota or an IVL, right, cutting balloons may work. When you look at rotational atherectomy, it is clearly mentioned that it might technically be required in cases of tight calcified lesions to allow subsequent passage, but it should not be performed routinely for de novo lesions or even in in-stent restenosis. So obviously there is an acceptance to a C, that heavily calcified lesions wherein nothing else goes before your stent implantation, there is an acceptance that rotational atherectomy has its place, but so does IVL, right? And there is these techniques do not fight with each other. Basically they are meant to be used synergistically, complementing each other, right? And they are good technologies to be used in a justified manner in the case in which one justifies the other. So that is how we should proceed. If you look at the strategy for calcified lesions, right, if you look at PCI, you have taken a patient, you have done an angiogram, you find angiographic calcification. If you look at if it is a mild appearance of calcification, possibly a non-atherectomy strategy would work. If it is a moderate, that is where the problem lies, whether you take an upfront decision or whether you would possibly go with a non-atherectomy first. But here imaging would help you. Look at IVES or look at OCT, which would be even better possibly, and then if you find it is mild, then possibly you can go for non-atherectomy. But if it is moderate or severe, you can straight away upfront go with an atherectomy strategy, right? And ultimately also, when you, in Sir's case, as he had a strategic failure in his case, you could straight away go to an atherectomy strategy. So the strategy for calcified lesions, people who go out of this room should have a very clear idea what device to use when and what strategy to use, and that should be the purpose of this particular debate, right? If you look at rota, as sir mentioned already, invented history, everything is there, but there are limitations. We have already seen the indications, but we didn't concentrate much on the limitations, which I would be focusing on, so that we know, and in this particular case they are particularly very relevant. So there is slow flow. In our case it is already present. There can be perforation, there can be CPKMB or troponin rise, so there can be evidence of MI. there can be spasm and dissection, that it is technically challenging, which are already accepted that it's a steep learning curve, so this is something which we already know and we already accept, and there can be heat generation. When everything rotates at about 160, 180, there is going to be a heat generation. Right? Contraindications, we have already seen that, sir already mentioned, eccentric lesions and tortuosity, which is already there in our case mentioned, so there is a tortuosity and therefore possibly to a certain degree a limitation, I would not say a contraindication. Important trials, already mentioned by sir, lot of trials he mentioned, I will just show you a few trials, and what he showed was that the choice of a burr is very important. So ultimately how does that come from? That comes from the operator experience. Not anybody can use a rota straight away, first case I will do rota is not possible, you require a learning curve with it. While we have grown up with balloons, we know how easy it is to use balloons most of the times, but with rota you require some degree of experience. So choosing an optimal to artery burr is very important, because if you not do that, then you can have problems with the burr, you can have entrapment, you can have stalling, and you can have so many other problems, even perforation. So all those things are very important. So ideal optimal burr to artery ratio is very important. And if you look at the same Mount Sinai experience, you could see that over a period of time, if you compare 94 to 2007 and 9, as they got experienced and they used lower speeds, right, their results improved. Otherwise they had high results of slow flow, they had major complications and also perforation, but over a period of time those results improved. So clearly shows that operator experience is very, very important. And if you look at the rota and BMS and DES data, you could see that all of these trials have shown higher MI rates, post-procedural MI rates, everything, because the debris simply goes down into the system. So obviously the MI rates are going to be higher, stent thrombosis is possible, but to a certain very low degree. 30-day MACE events, and if you look at TVRs, right, with DES, obviously the rates were lower. If you look at the Rotexus study which sir mentioned, it was efficacious, but at the same time look at the complication rates. When you look at the PTC and the rota, right, the excess site complications, the MACE events, if you look at death and MI comparable, but you look at the TV re-PCI, all of those things, rota PCI, you can have a marginal incidence of perforation or a burr entrapment, and you may require an emergency bypass surgery. So albeit small, but there are incidences of grave complications which do happen, particularly with inexperienced operators, wherein rota use may lead you to trouble. If you look at the complications, now rota, when you use that complications, you have to be aware of. You may tackle them, but you need to be aware of. You just can't go blindly. So you can have bradycardia, AV blocks, you can have slow flow or low reflow, you can have vasospasm, you can have dissections, perforations, side branch occlusions, hypotension. Now these are the ones which are very, very common and which are related to the particular patient subset also, as well as due to inherent problems with the rota system or the technique, the technology itself. And then there are also the possibilities of burr entrapment, burr detachment, burr stalling, and the guide wire fracture. In short, I will just cover all of these things. The problem is, these complications. If you look at bradycardia and AV block, we know that it is more common with RCA, and it can instantly occur after activating the burr, or it can follow a slowing trend of the burr. So there are problems, we need to tackle them, we need to be aware of. What are the mechanisms? Most of them are unclear, but there are various theories. It is said that microparticles can interfere with the vessels which are perfusing the AV node. There are possibility of vibrations at the heat of the burr itself which can cause a reflex bradycardia. So this is bradycardia. Slow flow and no reflow, very common. We saw in sir's case as well, and already this case has some slow flow. So it is observed in 5% of the patients who are undergoing treatment with rotablator. And how it is identified is by the diminution of flow by 1 to 2 TIMI grades, and no reflow is a complete cessation of flow into the distal vessel, and thereby you can have a patient can have chest pain on the table, there can be STT changes, there can be hypotension. All of these things are possible. What are the mechanisms? Plaque burden, long lesion. In this particular case we already have that. Non-STEMI thrombosis can already be there. Long ablation time, vasospasm, platelet activation, microparticulate aggregation, and in the previously infarcted segment, if you treat it, you can definitely have more chances. Dissection, 10%, we already know, because of the guide wire bias, you can very easily have a dissection. You can see this tortuous vessel with the wire bias, it can hug the side wall and it can actually burr the normal vessel as well. So dissections are possible and you may have to deal with it. Perforation, dreaded complication, 0.7% from the multicentered registry, less than 1%, but definitely known and can definitely happen, and typically in severely angulated lesions, perforations are typically more common, and particularly if you oversize the burr, as compared to the vessel size, then it can definitely lead to this. Side branch occlusion, yes, definitely possible, because the burr can actually go there, and you can have the problem with the side branch. Hypotension with vasospasm, bradycardia, slow flow, inadequately hydrated patients, or large doses of vasodilators, you can have hypotension as well. And further, as I mentioned, you can have system failures like entrapment, detachment, stalling, and also guide wire fracture. So I will not go into too much details of those, but yes, they are possible with rotablation. So just to list the potential disadvantages, the first thing that I would mention would be a steep learning curve, which quite a few people, and thereby there is an inertia to immediately initiate with rotablation. Operator experience and acquaintance with technique is essential for good acute and long-term result. Relatively cumbersome and a meticulous setup is required. It is not just that you get in, chalo rota karte hain, and then you get a rota done. It's not that way. You require a lot of equipments there to be set up there. Long list of potential complications, but yes, the new Rota Pro, when we talk about cost, even that cost differential has now come down when you compare to vis-a-vis IVL. And psychologically, just that simple concept of, if you ask a patient or a person in particular, you can ask him whether he would like that idea of a drill going inside. There might be some inhibition as well. So all of those things are there. So what next? What option do we have now? So if you see, this is lithoplasty, lithotripsy, and a comparison, if you see, it is just a balloon which all of us are ingrained with, all of us are trained with. It is a simple balloon, where you have got those sound transmitters, and the basic mechanism is you are not breaking anything, you are just cracking something so that the next modality can just take over, right? So therefore it has its set of problems, but then it doesn't mean that it is to be shunned off just because that it is a little bit more expensive. But if you look at the advantages, the convenience, and the the less steep learning curve that it provides, I believe this technology is here to stay, and it will knock out anything there which is there existing. So you could see the cracks of calcium that this produces, and with beautiful safety outcomes with the disrupt CAT trial, you could see that the MACE events, perforation, and whatever complications with rotablation had were not seen with IVL. So therefore the problem can be that eccentric calcium, and you could see that non-crossable lesions, IVL may have a problem, but vis-a-vis, if you look at rota, you can see thick focal circumferential calcium and the depth of calcium and deep calcium. This is the therapy which scores clearly over rotablation and will be the modality of choice when you look at deep calcified lesions. Summary and conclusions, I think you can also answer in rebuttal, but yes, extent of this is, I already have covered most of the things, right? It is a synergistic technique. We can combine both of them in certain particular cases, and then you can possibly do a rotatripsy. In this particular case, I am pretty sure that if the balloon can go in, IVL will definitely go in, and we would avoid slow flow perforation dissection in this particular case as mentioned above. Thank you.
Good afternoon, chairperson, moderators, and all the colleagues. Sid, you heard the previous two talks. We described in detail the technology which we use for the calcium, that is rotational atherectomy and IVL. I'm not going to speak about very unique technology which is very simple and still very effective and not expensive. Okay, so the implications of coronary calcium. If patient is moderately or severely calcified artery, then makes the procedure very difficult. It's very difficult to get a good acute outcome, as well as if you don't get a good immediate outcome, then chances of getting a long-term outcome are also very poor. So basically, how to tackle the calcium? Basically broadly we have two technology. There is balloon-based techniques and ablatory techniques. The ablatory techniques, they reduce the calcium burden, is the basically calcium volume reduction. In addition, they also create, they are effectively creating cracks. So most commonly used technique in our country is rotational atherectomy. Other techniques are orbital atherectomy and excimer laser. Now the balloon-based techniques include non-compact balloon, super high pressure balloon, there is open NC balloon, different scoring balloon, score flex, cutting balloon, angioscope, NC alpha, and the latest addition is intraosseous lithotripsy. So balloon-based techniques, how they work with the calcium? They do not remove the calcium, but because of the high pressure which they generate, they create the cracks in the calcium. And if you create the cracks, then only you will expand the lesion and stent. All these balloon-based techniques are advantage because they are very simple to use. Everybody can use it. they are user friendly. Today I am going to talk about the OP-NC balloon, which is unique Swiss-made CE-marked plaque modification device, which is highly non-compliant to ultra-pressure double-layer balloon. So what is unique about this technology, OP-NC balloon? There are two layers which gives good power to the balloon. In addition, despite having two layers, is a very low balloon profile. The crossing profile is very less, 0.228 inch only. The lesion entry profile is also very low, 0.016 inch. It has got 2 folds in the small diameters and 3 folds in the large diameters. And got 2 markers, even in small size, you got 2 markers, so you can precisely place the balloon. So these are the 3 important features of this technology. It's a twin layer, linear compliance, and increased tensile strength. All these 3 things are very, very important when you are going to treat the calcium. Ultra pressure, the highest rated RB blood pressure of 35 atmosphere of pressure among all the balloons available in the market. And because of high pressure, RB high pressure which you generate in the balloon is able to crack the cracks in the calcium very easily. And each balloon is factory tested at around 45 atmosphere of pressure. And the cardio is around high pressure, 50 pressure with the OP-NC balloon with a success. Second important feature of this technology is uniform expansion with virtually no dog boning. So it creates less dissection and perforation. The conventional non-compliant balloon, though they are considered non-compliant, but when they are inserted in a calcified registered lesion, they do develop dog boning at the end of the balloon because of very resistance lesion in the center of the lesion. When the OP-NC balloon, there is virtually no dog boning. Even if you go to very high pressure like 35 atmosphere pressure, there is linear compliance and cause no dog boning, so it is very safe. So less chance of perforation as well as the dissection. And the third important feature of this balloon is ultra low compliance. If you get linear compliance, it goes less than 10% even at pressure as the highest 35 atmosphere pressure. It is the lowest diameter compliance rate over the largest pressure range of any PTC balloon on the market. As you can see, the compliance cover OP-NC balloon with all size, even if you go from 10 atmosphere pressure to 35, it grows less than 10%. So that increases the safety of the procedure as well as the efficacy of the procedure. It has got the highest working range. If you compare to the other conventional non-compliant balloon, their working range is nominal pressure and rated burst pressure. RBM minus nominal pressure is working range of any balloon. So the conventional NC balloon, the working range is about 8 to 10 atmosphere pressure, while the OP-NC balloon, the working range is very high, around 25 atmosphere pressure. So there are certain tips and tricks of using the OP-NC balloon in calcified lesions. Avoid polymer sleeve wires because when you go to high pressure, it compresses the inner lumen and sometimes it's difficult to remove the balloon from the wire. So if you are going to very high pressure, more than 30 atmosphere pressure with OP-NC balloon, it is always advisable to keep one extra wire along with the previous wire. So in case your balloon is stuck on the wire, you can easily remove it without any losing access. Use extra small guide wires so you can easily access the lesions. Always start from a distal lesion and then come back proximally because once you inflate the balloon, the profile worsens. Always increase the pressure gradually. For first 20 atmosphere pressure, you can increase it very fast. But once you reach 20 atmosphere pressure, then increase pressure very gradually, every 5 atmosphere for about 10 to 20 seconds. And allow balloon to work and deploy before increasing pressure. Meaning that even if your inflation device shows the pressure of 30 atmosphere pressure, the same pressure may not be available in the balloon at that time. So better to wait for 5-10 seconds so the balloon is, the pressure in the balloon, inflation device gets transmitted to the balloon. And the sizing of the balloon is also very important. With the perforation with the OP-NC balloon is not related to the pressure, but is related to the size of the balloon compared to the diameter of the vessel. So pre-dilation and treatment of ISR always use point from the lesser diameter than the reference vessel diameter. And for post-dilation, you can use 1:1 balloon to vessel ratio. There are a lot of reports, some registry data and anecdotal case reports with OP-NC balloon in resistant calcified lesion. there is only one small ISAR randomized trial in which they compared the OPNC balloon versus the scoring balloon to prepare the severely calcified coronary artery lesions. All these patients initially had a treatment with the non-combined balloon, and on the failure of non-combined balloon, the patients were randomized in the two groups. The OPNC balloon group and the super high pressure balloon was used, and the other group they used the NSC alpha balloon, which is the 3 scoring balloon elements. And with the OPNC balloon and NSC alpha scoring balloon, there was comparable stent expansion on intravascular imaging. However, angiographic performance was slightly better with the OPNC balloon compared to the scoring balloon. This is a pooled analysis of 2 trials, which my previous speaker has described the prepare case study and result trials, in which total 274 patients were assessed, and out of which only 200 patients who had OCT image available after stenting, they were included in the pooled analysis, and it showed that the rotavators, though it was more effective, statistically 100% compared to the OPNC balloon or the modified balloon. However, the stent expansion was similar between the 3 groups, rotavator, modified balloon and super high pressure balloon, while stent extending index was better, much better with the OPNC compared to rotavator as well as the modified balloon technology. So now, with this brief introduction of the OPNC balloon, we are going to discuss a current case. That is 75-year-old male patient, non-STEMI, 19% calcified lesion, tortuous, long lesion with TIMI II flow, with slightly reduced ejection fraction and positive biomarkers. So, which is the base device for this patient? So, out of the 3, rotational IVL, and OPNC balloon. I will try to convince you that why OPNC is superior in this particular patient. Of course, we need some more information to select the appropriate device for lesion preparation in this patient. Angiography film to assess the degree of tortuosity, lesion length, vessel diameter, and thrombus burden. And intracoronary imaging is extremely important to know the calcium burden, calcium location, and morphology. Basically, we are interested to know the calcium thickness, calcium length, whether it's concentric or eccentric, is calcium nodule is there or not, vessel diameter, and guide wire bias. So this is the ideal case. If you want complication with rotation, then this is the ideal case. Why? Because it's a very long lesion. So what do you mean by long? If your long lesion is long, if you do rotation, then there is more plaques. You are going to generate more debris and more distal emulsion. Secondly, with long lesion, you are likely to have a prolonged ablation time. In addition to long lesion, this patient has tortuous lesion. So tortuous lesions always needs more time to cross with the rotavator burr. This patient has already a slow flow, and if you use rotavator, it is likely that flow can worsen. And why this patient has slow flow? It is likely that this patient might be having thrombus, though it is not visible on the angiogram, because the patient is non-STEMI, he is resting disease changes, he is elevated troponins, and he has TIMI II flow. So because it is a long lesion, tortuosity, and probably thrombus lesion, chances of complication will be extremely high if you do rotavator in this patient. Secondly, there is high risk of perforation also, because this patient has a very tortuous artery. So rotavator wire bias is very difficult to predict on angiography. See, wire bias is strong toward the healthy side, it can easily lead to vessel injury. So the experienced operator will use smaller burrs to prevent perforation in such a tortuous segment. But if it is a small burr, then you are going to have inadequate plaque modification. That's why I believe the rotavator is not a correct choice for this patient. Now what about IVL? IVL challenge will be too difficult to deliver because of long tortuous calcified lesion. An IVS catheter is a bulky catheter. If you compare the crossing the whole IVL balloon's profile is 0.044 to 0.047 inch. Compared to OPNC balloon, which profile is very small, like 0.028 inches, which is like conventional NC balloon. So, the first problem is IVL will be difficult to deliver in this patient. And second problem, more than one balloon may be required in this patient. Why? There is a long lesion length. Is the lesion in the LVEF. So already usually tapers from proximal to distal segment. So with very long lesion, you may need a very significant diameter difference in the proximal end of the lesion and distal end of the lesion. And when you use IVL, you to start IVL 1:1 to artery ratio, balloon to artery ratio. So with very long lesion, you will end up using 2 balloons. So it becomes very expensive. Secondly, IVL balloon also sometimes ruptures. There is some registry data in the real world experience, and they show the rupture of IVL balloon was almost 4 to 5%. In case you rupture in such a long lesion, you will require 3 balloons. So it will be almost impossible. Probably cost very expensive. That's why I believe that in this particular patient, OPNC device is my device of choice. Because the ease of use is very effective to treat calcium, is very safe, loads to perforation and distal embolization, is a better crossing profile so it is easy to advance the balloon in the calcium lesion, is a time-tested device, there is a clinical experience of more than 10 years, and is cost effective also. You can easily use 1 or 2 OPNC balloons without any problem. So thank you for your attention.